Hi guys, and welcome to another crash course video. So today we're going to be covering heart failure. We're going to be covering what is heart failure, some symptoms, pathophysiology, clinical examination, history and some OSCE tips, and then we're going to finish on a summary and some questions. So what is heart failure? Heart failure is defined at the point at which the heart can't supply enough blood to meet the body's demands, and this can occur in one of two ways. Either the ventricle cannot pump hard enough during systole, and this is known as systolic heart failure. It's also known as HFrEF, which is heart failure with a reserved ejection fraction, as you aren't pumping as much blood out of the heart and therefore around the body. The other type of heart failure is when not enough blood fills the ventricles during diastole, and this is known as diastolic heart failure or HFpEF, which is heart failure with a preserved ejection fraction. The muscles of the heart are contracting normally, but the muscle has thickened, meaning that the ventricle holds a much smaller amount of blood. The two types of heart failure can occur on the left or right side of the heart, but left-sided heart failure is much more common than right-sided heart failure. As blood isn't being pumped out of the heart as efficiently, it starts to back up into the lungs and causes congestion, which is why you can see heart failure referred to as congestive heart failure as well. So signs and symptoms. So here we have some common signs and symptoms of heart failure. Dyspnea or shortness of breath can occur on exertion or at rest. As heart failure develops, the intensity of exercise resulting in breathlessness progressively declines until it can occur even at rest. Breathlessness is caused by a decreased pulmonary function, secondary to decreased compliance and increased airway resistance. And compliance is the lungs' ability to stretch and expand. The low cardiac output in heart failure causes hypoxemia, which is low levels of oxygen in the blood, and an increase in carbon dioxide production. So the breathlessness is an attempt to expel this extra carbon dioxide. There can also be respiratory muscle dysfunction due to ischemia, causing a reduction in respiratory muscle strength. Orthopnea is another early sign of heart failure and is breathlessness when lying down, which is usually relieved by the patient propping themselves up with pillows. And when lying down, there is decreased pooling of blood in the lower extremities and the abdomen, as it is displaced to the thoracic compartment. And the heart cannot deal with the excess blood, meaning pulmonary, venous and capillary pressures rise further, resulting in pulmonary edema, reduced pulmonary compliance, increased airway resistance and therefore the breathlessness. It can be so severe that patients aren't able to lie down and need to sleep sitting in a chair. A cough can be related to the orthopnea, and that would be non-productive, but the cough may also be caused by pulmonary edema, which would be productive, and the patient would have pink frothy sputum. Pulmonary edema will also cause the patient to be pale, sweaty, tachycardic, hypoxic, and using their accessory muscles to help them breathe. The tachycardia therefore causes the patient to have palpitations, as this is one of the compensatory mechanisms of heart failure. Edema in the legs, ankles and feet may also occur, particularly at the end of the day or after prolonged sitting. The swelling can be so severe that it reaches all the way up to the abdomen, causing ascites. Nocturia can occur because when the patient is lying down, renal vasoconstriction diminishes and the urine formation increases. An oliguria, which is very low urine production, but it's a late finding in heart failure and is found in patients with markedly reduced cardiac output. So causes. Anything that causes myocardial damage may lead to heart failure. So some examples include ischemic heart disease, hypertension, atrial fibrillation, valvular disease, cardiomyopathies, infective endocarditis, anemia, endocrine disorders, and this last one, cor pulmonale, is right ventricular failure, which is secondary to pulmonary disease. All of these will cause a reduced myocardial efficiency, as there will be increase in workload but reduced cardiac output and reduced contractility. So just to explain that in a little bit more detail, the cardiac output is the amount of blood pumped by the heart over a given time period, and to work out the cardiac output we multiply the stroke volume, which is SV, by the heart rate, which is HR. The stroke volume is the amount of blood ejected by the ventricle per heartbeat and is calculated by minusing the end diastolic volume and the end systolic volume. The SV is affected by three factors: preload, afterload and contractility. Preload is the volume of blood or the amount of muscle fibre stretching the ventricles at diastole, and afterload is the resistance that the heart has to overcome to eject blood during systole. Contractility is the intrinsic ability of heart muscle to generate force and shorten, independent of changes in heart failure, preload and afterload. The ejection fraction is calculated by dividing the stroke volume by the end diastolic volume and multiplying by 100. So a fall in cardiac output is usually due to a decline in the SV. That can be systolic or diastolic function. And then you get activation of compensatory mechanisms to maintain the cardiac output, but this will worsen your cardiac function over time. So compensatory mechanisms, so as we've got increased workload but a reduction in cardiac output and contractility, certain compensatory mechanisms are activated to compensate for this excess workload. So within the heart we'll have the Frank-Starling mechanism, which relates preload to force of contractions. We'll have hypertrophy, which is an increase in the size of the heart muscle in order to produce more forceful contractions, and tachycardia, which is an increase in heart rate in an attempt to pump more blood out of the heart. Some of the hormones involved include the RAS system, vasopressin or ADH, natriuretic peptides like AMP and BMP, and circulating catecholamines like adrenaline and noradrenaline. There'll also be an increase in sympathetic activity, but a reduction in vagal activity to the heart. And although all of these are important in the compensation in the early stages of heart failure, the long-term results of their activation results in ventricular remodeling, which ultimately worsens myocardial dysfunction. So the Frank-Starling principle, and that refers to the relationship between preload and cardiac output. It states that increasing preload will increase the force of contractions. This compensation will work for a while, but over time muscle fibres will become overstretched for dealing with the increased preload, and they won't be able to create contractions forceful enough. Therefore, you'll get a reduced stroke volume, and as your stroke volume is directly related to cardiac output, you'll have a decreased cardiac output. So the RAS system, activating beta-1 and alpha-1 receptors in peripheral vasculature and the decreased renal perfusion both cause the activation of the RAS system. Angiotensin II causes vasoconstriction and increased preload by stimulating thirst and promoting aldosterone release. The aldosterone will increase water retention by sodium resorption, therefore increasing preload. There will also be an increase in the secretion of ADH, which is induced by arterial baroreceptors and by the increased levels of angiotensin II. When pressures are detected by the baroreceptors, their inhibitory impulses to the hypothalamus are reduced, leading to an increase in the release of ADH from the posterior pituitary. ADH will promote water retention in the distal convoluted tubule of the kidneys and will also increase preload. So natriuretic peptides. The main natriuretic peptides include atrial natriuretic peptide or AMP and brain natriuretic peptide or BMP. They serve to counteract the vasoconstricting effects of the other neurohormonal systems that we've mentioned, such as angiotensin II and aldosterone. AMP is found in the atrium and BMP is found in the ventricles, and they are released following atrial or ventricular stretch. They act directly on blood vessels to cause vasodilation, cause salt and water excretion, and as we've said, they'll inhibit the secretion of renin, aldosterone and ADH. Elevated BMP is thought to be one of the first signs of heart failure and is used in diagnosis and following the progression of the disease. There's also another natriuretic peptide called C-type natriuretic peptide or CNP, which is found predominantly in the central nervous system and it has some similar effects to AMP and BMP. The decreased cardiac output will be detected by the baroreceptors, like we said, and these are mechanoreceptors located in the carotid sinus and the aortic arch. They'll detect the change in pressure, as a decreased cardiac output means a decreased mean arterial pressure or MAP. This leads to the stimulation of the sympathetic nervous system, which releases adrenaline, noradrenaline, and these have direct effects on the heart by increasing heart rate and contractility. ADH is also released, which acts on the peripheral vasculature and causes vasoconstriction to increase the stroke volume. So we've got a history here. An 80-year-old male presents to his GP with shortness of breath, a non-productive cough and nocturia. His shortness of breath occurs when he walks to visit his daughter. He has also noticed that he has to sleep propped up with a couple of pillows more recently, as his breathlessness seems to be worse when he lies down. His cough also seems to be worse when he lies down. So what might we want to do next? So you can pause the video here and have a little think about his symptoms and what you'd want to do. So we'd obviously want to do a CVS examination, and that would include listening to his lungs as well. So on examination, the patient isn't short of breath at rest and seems to be comfortable. You find that his BP and pulse rate is increased. He seems to have slight heave on his left side. He has pitting edema in his ankles. His lung sounds are normal though. So what do you think that the differential diagnosis would be? And again, you can pause the video and have a little think. So the differential diagnosis for this patient seems to be early heart failure, but why is this? So to start, we can look at his risk factors. He's male, he's over 70, and he has hypertension, which is one of the causes of heart failure. He had exertional dyspnea and orthopnea and sleeps with a couple of pillows, as well as a non-productive cough, nocturia and some edema in his ankles. These are all early symptoms of heart failure. When you examined him, his blood pressure and pulse rate are both raised. He has a slight heave, suggesting his heart is working harder to compensate for a decrease in cardiac output. His lung sounds are normal and his cough is non-productive, meaning his heart failure hasn't progressed enough for there to be pulmonary edema yet. Okay, so some OSCE tips. Remember to check the pulses. Remember to check the patient's blood pressure. Remember to check for temperature and peripheral cyanosis. Remember to check for heaves and thrills. Remember to check for the JVP, which is what's raised in right-sided heart failure. Remember to listen for the third heart sound. The third heart sound is usually due to volume overload, which is obviously the most common presentation for heart failure, and it's best heard at the apex with the bell of the stethoscope, so where you'd listen for your mitral valve. Remember to take the respiratory rate and listen to the lungs. Tachypnea and rales or crackles and a wheezing could indicate pulmonary edema, which is secondary to heart failure. And pleural effusions are also common in patients with elevated cardiac pressure as well. The edema may also be in the peripheries, so also remember to check there, or you can check the sacrum if they've been lying down for a long period of time. Ascites is also associated with chronic heart failure, so you might want to have a look at that as well. Okay, so there's just some questions to finish on. So what is systolic heart failure also known as? Is it HFrEF, HFpEF, right-sided heart failure, or left-sided heart failure? And for this question, you just need to think about what is happening during systole. So you might want to pause the video and just have a little think about what your answer would be. So the answer would be HFrEF, so it's heart failure with a reserved ejection fraction. Question 2. Which compensatory mechanism increases contraction in response to preload? Is it the RAS, AMP and BMP, Frank-Starling mechanism, or the sympathetic nervous system? And you want to think about which compensatory mechanism is maintaining left and right ventricular output. So the answer would be the Frank-Starling mechanism in this case, as it directly relates an increase in preload to an increase in the contraction of your heart. And finally, question 3. Why might a patient experience dyspnea with heart failure? Is it because of decreased pulmonary function, an increased airway obstruction, reduced compliance, or reduced compliance and increased airway obstruction? And you just got to think about kind of what's happening in the lungs to cause breathlessness. So the answer would be reduced compliance and increased airway obstruction. Decreased pulmonary function is causing dyspnea and heart failure, but that's secondary to the reduced compliance and increased airway obstruction. Okay, so thank you very much for listening, guys. If you've got any feedback for us, do let us know, and we'll see you in the next video.